Hi, good evening everyone. So with the part 2 of this series, we'll be continuing our discussion on the use of systemic corticosteroids in dermatology. In the part 1 video, the previous to that, we were discussing about various different types of steroids, what were the mechanism of action, and what were the major uses in dermatology, and what are the different aspects of different type of steroids and the changes, or you would say the variability in their glucocorticoid action and the mineralocorticoid action. In this presentation, we'll be talking about majorly the adverse effects. Why do they happen? What all type of adverse events do we see with corticosteroids? And how should we manage them, monitor them, look for them, and treat them? In my opinion, the major fear of using corticosteroids in our patients are the related adverse effects. So if we know about them, we'll be able to better use those drugs in our patients and we'll be able to help them in managing various sorts of inflammatory induced or inflammatory associated dermatosis. Okay, so with this presentation, we'll be starting our discussion on adverse effects in dermatology. Now, just an introduction that our body requires a certain basal level of cortisol, and the baseline production of cortisol is roughly equal to 20 to 30 milligram a day. That means every day our body is going to produce 20 to 30 milligram of cortisol, which is roughly equivalent to 5 to 7.5 milligram per day of prednisolone. Okay, so every day this amount of steroids or endogenous steroids will be produced by the body to carry out its daily function. And what are those functions? There are two major types. One is glucocorticoid, the other is mineralocorticoid. So glucocorticoid is responsible for increasing the level of glucose in the blood to provide energy to cells or the body. The mineralocorticoid has an important action regarding control and maintenance of blood pressure in the body. So these two are the general mechanisms or general functions of endogenous steroids, and they are carried by the daily production of 20 to 30 milligram of cortisol. If the body undergoes stress, the maximal stress production of cortisol increases to about 10 times to 300 milligram per day. That means if body is undergoing any kind of stress, the level of cortisol will rise around 10 times the baseline production of cortisol. And if we compare it to the prednisolone equivalents, it is roughly equal to 75 milligram a day. That means in the time of stress, steroids levels produced in the body are roughly equivalent to 75 milligram of prednisolone. So, and if there is minor stress, not a major one, this is talking about major stress. Okay, so if we are talking about minor stress, it is about 2 to 3 times the normal baseline production of cortisol. Clear? Now, when we are starting to discuss about the adverse effects of cortisol, it's very important to understand its effect on hypothalamus-Pituitary-Adrenal axis. Now, this axis is responsible for the production of endogenous steroids. And whenever we are going to supply steroids from the outside, the exogenous steroids, this will lead to suppression of HPA axis. Okay, it acts as a negative feedback. Clear? So the normal axis starts from this area, which is the hypothalamus. This green shaded area is hypothalamus. This hypothalamus is going to release a chemical known as corticotropin releasing factor. Now what this CRF will do is it will act on anterior pituitary. Okay, anterior pituitary, and anterior pituitary is going to secrete a chemical known as adrenocorticotropic hormone, ACTH. So remember, it is tropic hormone, not trophic hormone. Okay, adrenocorticotropic hormone. Roughly about 10 bursts of ACTH are secreted in a day by pituitary. Okay, so pituitary is going to release this ACTH in a pulsatile manner, and this will be roughly about 10 pulses in a day, and majority of these pulses occur during the sleep. So when we are sleeping, this pulse is going to occur. We'll be discussing the level of cortisol in the body in response to these pulses in subsequent slides. Okay, so most of these occur in sleep and during the early morning hours. Okay, during the early morning hours, and that is why you will see the levels of cortisol in the body rising in early morning hours, and that is why we should give steroids in early morning. We'll be discussing that in detail, don't worry. Okay, Now, hypothalamus is very easy to get suppressed by exogenous steroids. That means the steroids, if we give it from outside the body to the patient, this organ will be the first to get suppressed, and consequently, when the steroids are stopped, this organ is the first to come back, the first to revert back to normalcy. Okay, so hypothalamus are first to be suppressed and first to recover to its full function. It's a critical component of stress responsiveness. It's the master manipulator of the indigenous steroid production. Now, what this ACTH would do, ACTH will act on the adrenal gland, the cortex of the adrenal gland. Okay. Now, this cortex of the adrenal gland is going to secrete cortisol. Cortisol or cortisone, these are endogenous steroids. Okay. Majorly hydrocortisone and hydrocortisone. Okay. These are endogenous steroids. Now, there are multiple factors which are controlling this cycle, this HPA axis, and I will not go into details of those external factors. Major factor is this cortisol. It acts as a negative feedback. That means it will act negatively on ACTH secretion. That means increased cortisol will lead to decreased ACTH. It's a control in the normal flow of HPA axis. And additionally, it will also act as a negative feedback to CRF release. So, the more the cortisol, the more will be the inhibition of the HPA axis, and it will kind of counteract its own production. So if we give steroids from outside, more will be the circulating steroids and more will be the HPA axis suppression. Clear till now? And this cortisol will then go through these blood vessels into the plasma as plasma cortisol, and this will be around 80 to 90% bound to plasma proteins, which is the corticosteroid binding, cortisol binding globulin, which we had discussed in the previous presentation, and the rest free part, around 10%, 1 to 10%, will be the one carrying out its glucocorticoid and mineralocorticoid effects. Clear till now? Now let's study the adrenal gland in a bit more detail. Now, adrenal gland has predominantly three parts. One is the outside capsule, then the inner cortex, and then the innermost medulla. Clear? Now, cortex has further three parts: glomerulosa, fasciculata, and reticularis. You can remember it as GFR, glomerular filtration rate. Okay. So, from outside to inside, it is a thin part is glomerulosa. The thicker major part, which is roughly equal to 80% of the adrenal cortex, is fasciculata, and the reticularis makes the lowermost thin part, lowermost 10% or so. Clear? Now, what glomerulosa does is, glomerulosa releases aldosterone, which is the endogenous mineralocorticoid. It is a mineralocorticoid which will act on the kidneys and maintain the blood pressure. Clear? The fasciculata will secrete your major steroids, which is cortisone. Okay. The reticularis will secrete androgens. And these androgens will go into the gonads and convert into testosterone and estrogen. Clear? We won't be discussing, we will just discussing cortisol. And medulla is going to secrete catecholamines like adrenaline, noradrenaline. Let me just write it clearly. Medulla is going to secrete catecholamines. Clear enough? So we'll be dealing with only fasciculata. Now, whenever we give exogenous steroids, it will suppress the axis. That means more the steroid in the system, more will be the suppression of the HPA axis, and the endogenous steroid will be less than 10 microgram per deciliter. If it is less than 10 microgram per deciliter, we say it as HPA axis suppression. Okay, Hypothalamus-Pituitary-Adrenal axis suppression, when the concentration of endogenous steroids gets less than 10 microgram per deciliter, or even plasma cortisol is less than 10 microgram per deciliter. And for this to be done, you have to stop all exogenous steroids 1 day prior to measuring it. Okay, 1 day prior, and you measure it at 8 a.m. early morning. So early morning you measure this cortisol, and if the levels are less than 10 microgram per deciliter, it is HPA axis suppressed. Whenever this is going to increase with more than 10 and to be on the safer side more than 20, that means no suppression is there, you can stop all doses of steroids. Clear? Let's go further. Now this is the cortisol levels in the body throughout the day, and we are just assuming that it's a diurnal cycle. Now we can see that it starts roughly at about 2 a.m. If the person sleeps at 12, roughly starts around 2 a.m. and gradually keeps on rising with the maximal level reaching at about 8 a.m. That is why we measure cortisol at 8 a.m. to know what is the maximum level of cortisol in the body, to see if the HPA axis is suppressed or not. As the day progresses, this cortisol level will keep on decreasing because the plasma cortisol is rising. So when it starts to secrete at 2 a.m., it will start to rise up slowly, and at the zenith of it, at the maximum level, it will start to inhibit its own secretion because of negative feedback, and the concentration of cortisol will decrease. Clear? That is why it is important to give steroids in the morning dose only, and we should not divide the dose into morning and evening doses. If we divide the dose into morning and evening, because we are giving in evening also, the cortisol level will rise in the evening, and there will be two peaks, okay, 1 and 2. And because of this 2 peak, the HPA axis will constantly be suppressed throughout the day, and this will lead to more HPA axis suppression. If we give it only in the morning time, the increased cortisol will be there only in the morning, and in the evening it will give time for HPA axis to get back to its normal levels. So we are giving some time for the HPA axis to recover if we are giving only the morning dose. That is why splitting of steroid doses in a morning and evening fashion is not recommended. The split dose is more immunosuppressive, but there will be a much more HPA axis suppression. I think it's clear up to now. So let's go further. Now, this is the same table which we had discussed previously in the last video regarding the effects, glucocorticoid and mineralocorticoid effects of steroids. We'll just be revising this table in just few seconds. So glucocorticoid is responsible to increase the glucose in circulation, and it is majorly responsible for the immunosuppressive action. So immunosuppressive action is because of glucocorticoid effects. Mineralocorticoid is supposed to maintain a normal blood pressure. Clear? Now glucocorticoid effects will lead to increase in glucose by gluconeogenesis. Also it will start a peripheral insulin resistance. So it will inhibit the uptake of glucose from the circulation into the cells. It will reduce the glucose entry into the cells, and it will increase the glycogen storage in liver. Clear? Additionally, it will increase triglycerides, and it will lead to fat redistribution at central location, leading to Cushingoid phases or a Cushingoid habitus. Okay, Cushingoid body type. Mineralocorticoid is mainly responsible for maintenance of blood pressure by using aldosterone and its effect on kidneys. We will not be discussing that much about mineralocorticoid. We'll be discussing subsequently when we are discussing individual adverse effect. So I hope it is clear that a major source of adverse events or adverse effects are the glucocorticoid action, and some of them are contributed by mineralocorticoid. We'll be discussing them separately. But if you understand what are the different glucocorticoid effects and what are the different mineralocorticoid effects, you'll be easily able to remember what are the adverse events of steroid usage. Now coming back to the hypothalamus-pituitary-adrenal axis, if the axis is suppressed to a major extent, or let's say you're giving steroids more than 3 weeks, significant steroids, that let's say more than 20 milligram per day of prednisolone, it will lead to HPA axis suppression. If the suppression is over a prolonged period of time, it might lead to adrenal crisis or Addisonian crisis. Now what do we mean by adrenal crisis? The adrenal glands don't produce enough cortisol and mineralocorticoids. That means the HPA axis is suppressed to that extent that the normal endogenous production of the steroids in the body is very low, and the adrenal glands are not able to produce enough cortisol. And that leads to decrease in plasma cortisol. So for example, let's say your body is producing 20 milligram of cortisol naturally every day, and in spite of that you're going to give 100 milligram of cortisol from the outside. Now the adrenal glands will think that we already have so much steroid in the system, I should stop secreting and making more cortisol. It will get suppressed. And when we stop the exogenous, the outside steroid, the adrenal glands don't have the capacity to secrete enough cortisol, and this will lead to adrenal crisis. One thing to remember is that it is life threatening. It can prove to be fatal. There will be increase in potassium and increase in calcium. Remember that when we give corticosteroids, there is hypokalemia. The potassium decreases. Remember that during pulse, we advise our patients to take a lot of coconut water and banana. We even supplement them. So normal steroids increase sodium and decrease potassium. And if the steroids are not in sufficient amount, the potassium will increase, calcium will increase. The major effect of glucocorticoid is to increase glucose, so the opposite will happen. Glucose will decrease, sodium will decrease, blood pressure will decrease, T4 and thyroid level will decrease. It will cause hypothyroidism. So these all will decrease, potassium and calcium will increase. And because of this electrolyte disbalance, you will have confusion, psychosis, slurred speech, lethargy, convulsions, fevers, vomiting, diarrhea, dehydration, syncope, or even orthostatic hypotension because blood pressure is not being maintained. And it's more of an acute event. Okay, so this is known as majorly adrenal crisis or Addisonian crisis. Another syndrome that we should learn about is steroid withdrawal syndrome or SWS. This happens when you give steroid for a prolonged duration and then abruptly stop it. So if you're giving steroids for a long duration, your body gets habitual to those doses of steroids and it will decrease its own steroid production. So if you stop steroids after a prolonged duration of steroid intake, this will lead to steroid withdrawal syndrome. There is no significant cortisol change in the plasma. The plasma levels might be near normal, not at all that much decrease, and this will lead to majorly physical symptoms. As we remember in the last slide, we were discussing more about confusion, slurred speech, and all those symptoms of adrenal crisis. This will be more of a physical symptoms like arthralgias, myalgia, mood swings, headache, fatigue, lethargy. Severe cases, it may lead to anorexia, nausea, vomiting. Your patient will say, if you stop steroids, your patient will say that I don't feel good now. Okay, I feel very tired. I'm not able to do my routine work. Please give me more steroids. Okay, so you have to make sure that the patient is not in steroid withdrawal syndrome, and you might have to give a little amount of steroids till the adrenal glands and the HPA axis reverts back to normal. Major cytokines that predispose or that carry out steroid withdrawal syndrome is interleukin 6, interleukin 1 beta, and TNF alpha. These are the major cytokines, and of these three, the major one is interleukin 6. So if a question comes that if steroid withdrawal syndrome is mediated by, one answer is interleukin 6. If more than one, then interleukin 1 beta and TNF alpha. Now remember that in HPA axis suppression, hypothalamus is the first one to get suppressed. It's the quickest organ to get suppressed because of extra steroids, and it is one of the most important organ of the whole axis. It is quickest to get suppressed, but it also reverts back to normal quickly. It's the first one to come back to normal. If you give high dose steroids for an acute duration, it will take around 14 to 30 days to come back. If the steroid is given for a longer duration, for a chronic duration, it might take as long as 6 to 9 months to come back. Clear? Now, what all cases you can have a high risk of HPA axis suppression if the dose is divided? Remember when we were discussing the plasma cortisol levels, and I said, I told you that this is the normal cortisol, and if you divide the doses into a morning and evening dose, this will lead to a much more HPA axis suppression, because this area which normally the HPA axis uses to recover itself will not be there, and there will be a prolonged suppression of HPA axis. Okay, and this will lead to a prolonged suppression and a more severe suppression of HPA axis. Additionally, longer acting steroids like Dexa and betamethasone have a prolonged you could say presence in the system, leading to a long duration of HPA axis suppression. So a high risk is associated with the divided doses, non-morning dose, giving it in the evenings, and a longer acting steroids. Off-day dosing is better. What is off-day dosing? That means every other day. You give steroid on one day, do not give on the next day, then again give on the one day, then again on the next day, so that you allow at least 36 hours for your HPA axis to come back to normal. Clear? So remember that when you're giving off-day steroids or alternate day steroids, you have to use intermediate acting steroids like methylprednisolone and prednisolone. You cannot use longer acting steroids like dexa and beta, because there will be a prolonged, the half-lives are nearly roughly equal to, if you remember the first slide, 330 to 300 hours. So there is no point in giving an off day because steroid will still be there in the system. Yeah, if you're giving an alternate day dosing, give methylprednisolone or prednisolone. Clear? Now, if you're suspecting HPA axis suppression or a patient has taken prolonged steroids either from you or from the outside, you need to find out whether the steroids, the HPA axis is suppressed or not. And for that, the first test that you can do is 8 a.m. cortisol. Okay. Now 8 a.m. cortisol checks the adrenal gland, whether the adrenal gland is making the steroid which is normally required or not. You check steroid at 8 a.m. You have to stop biasolone, or you have to stop steroids one day before. And if the level is less than 10 microgram per deciliter, you can say that the HPA axis is suppressed. Clear? You can also measure 24-hour urine-free cortisol. That means how much cortisol is there in the urine. Remember, in the first slide we were discussing that cortisol is excreted from the body through kidneys unchanged. So we'll measure the amount of cortisol in the urine, and if those cortisol is less, that means the body is not producing enough cortisol and HPA axis is suppressed. In ACTH stimulation test, for example, you have an adrenal gland and you want to know whether the gland is working properly or not. There can be two issues: whether the gland is not working properly, or it is not receiving good impulses from pituitary. So what you do is you give ACTH. If you give ACTH and then you measure cortisol levels half an hour and then 1 hour and 2 hours after the ACTH stimulation, and if the cortisol level which were initially low but now normal, that means adrenal gland is working fine. There is some issue in the pituitary. Okay. Now ACTH test, what we use is known as co-syntropin. Let me just write it properly. Co-syntropin. Okay, this is an ACTH analog and roughly the dose is 1 microgram, but there are other tests which use high doses of co-syntropin to the range of 250 microgram. Okay, now insulin hypoglycemia, in that what we give is we give insulin and then we check what is the levels of cortisol. Remember that glucocorticoids have an antagonist action to insulin. So if we give insulin, the glucocorticoid will rise to counteract the increased insulin. If it doesn't rise properly, that means HPA axis is suppressed. Other two tests I am not going to detail, they are not much important: metropon and corticotropin releasing factor. Okay. This test, the corticotropin releasing factor test, is the best out of the list, but it's very expensive. It is not done. Routinely, we just do 8 a.m. cortisol and ACTH stimulation test, and if possible, the urine catecholamine levels. Other than that, no test is usually done. Now, after HPA axis suppression, we'll be discussing each and individual side effects separately. So, hyperglycemia. Because of increased steroid, remember that steroid have glucocorticoid effect, and the effect of glucocorticoid is to increase plasma glucose, increase glucose in blood. So because of increased gluconeogenesis and increasing peripheral resistance, and this peripheral insulin resistance can happen within the 12 hours of administration. Now what that means is that when you give steroid dose, let's say you give steroid dose here, within 12 hours the insulin resistance will rise, but it will come back down with prolonged therapy. But if you are using steroids for a longer duration, or if you are using steroids higher doses or longer acting steroids, the insulin resistance might be more prolonged, and this will lead to increased insulin resistance. These cells in the periphery will not be able to uptake those increased glucose in the blood, and this increased glucose will lead to hyperglycemia. Few risk factors associated with hyperglycemia are obesity, okay, obesity, family history of diabetes mellitus too. These are two of the most important risk factors. If there's a family history of deranged glucose metabolism and glucose regularization, there will be an increased chance of hyperglycemia. Now, if you want to test whether the patient has hyperglycemia or not, postprandial hyperglycemia, that means after food intake hyperglycemia, is much more important test. The fasting glucose levels can be mildly elevated. So it's better to give the patient food, see how the body reacts to it, and if the glucose level rises as normally it should or not. If there's a less rise in blood glucose level, that means the internal steroids are not working properly and the axis is suppressed. If the patient has taken a lot of steroid, the axis will be suppressed and there won't be that much good rise in glucose. Now, if this glucose levels are increased to a larger extent, for example, you give food, let's say here, and this is the plasma glucose, the fasting glucose is less, but after food it increases to a lot more than the normal values. Now, remember what happens. Let me just clarify this quickly. Okay. Normally, when you take food, the glucose level will rise. That is normal. To counteract that increased glucose, insulin is also going to rise. Now, this increased insulin will shift glucose from the blood into the cells. That is in normal function, and the glucose level will then gradually go down. If there is peripheral insulin resistance because of increased steroids, this insulin resistance will not allow the glucose to go from blood to the cells, and the glucose will remain elevated for a prolonged duration. And this is the hyperglycemia because of insulin resistance. If the glucose levels are prolonged high, it may lead to diabetic ketoacidosis or even diabetic coma, and these two conditions are life-threatening. So you have to be very much on the lookout for these conditions. Treatment is you just ask the patient to take a healthy diet, maybe diabetic diet, home monitoring of blood sugars, insulin and insulin sensitizers. The most commonly that we use is metformin. Metformin also has an insulin sensitizing effect, and oral hypoglycemic agents. Basically, manage the patient as if they have diabetes. Clear? Now, remember that in hyperglycemia, if you're treating hyperglycemia, in case of diabetic ketoacidosis or diabetic coma, insulin might be justified. But if the sugars are just raised, giving insulin will not help, because remember that glucocorticoids are also causing peripheral insulin resistance. More the insulin, it won't be able to act because of resistance. So it's better to give insulin sensitizers with insulin, and you have to prevent that from happening. So ask the patient to take a balanced diet. Now, hyperlipidemia. Remember that glucocorticoids also increase triglycerides, and that is majorly because of its catabolic state. That means conversion of lipids to more glucose, and also increased lipoprotein lipase. Now, what lipase does is to increase triglycerides. So there will be increased TG, increased triglycerides in the circulation, followed by increased cholesterol. So these lipids will increase in response to steroids. Treatment is calories restricted, and also drugs like gemfibrozil and statins, which we usually the physicians use to control high cholesterol, can easily be used to control high lipids in this situation also. Now, Cushingoid syndrome. There is altered fat deposition predominantly in the central parts of the body. In central parts of the body, there will be fat deposition, and there will be increase in appetite. Because of increased appetite, see, steroids push the body in a catabolic state. That means body will start to produce, start to convert a lot of other molecules into glucose because of steroids, and there will be a much more conversion of energy-giving molecules like glucose, and that is known as a catabolic state. Now, in this catabolic state, the appetite will also increase, and because of increased appetite, there will be more intake of calories, leading to more fat deposition into altered areas, other areas of the body, and these fat deposition can lead to a buffalo hump or increased abdominal obesity. Now, it is seen in around 10 to 15% of patients, which quickly rise to 60% on long-term steroid therapy. That means steroid given for at least 2 to 3 months can lead to Cushingoid habitus. Now remember that 2 to 3 months is somewhat of a book figure. I have had patients who develop Cushingoid features as early as within 4 weeks, and we all have seen patients who don't develop Cushing's even if high dose pulse therapy. So remember that all of these side effects are seen to some extent. This you could say it's somewhat like a variable penetrance. It's not a good word to be used in case of drugs, but not all side effects are seen, and not all side effects are seen to equal extent in different patients. Okay, best is to keep on measuring weight. If you're giving corticosteroid to your patient, keep on measuring weight at each OPD visit. Treatment is diet, exercise. Make sure you taper the steroid when the need is over. You taper the steroids and stop it, or shift the patient to steroid-sparing drugs like other immunosuppressives like azathioprine, methotrexate, cyclosporin, etc. So shift the patient, stop steroids. The Cushingoid habitus will gradually resolve with exercise. Now here we are just enumerating the side effects of corticosteroids. So moon faces, buffalo hump, obesity, thin and wrinkled skin, increased abdominal stria are all seen in Cushingoid habitus. The other side effects we are going to discuss slowly subsequently. Now, previous all side effects were glucocorticoid side effects. Remember that these were because of exaggerated glucocorticoid response. Hypertension is a mineralocorticoid side effect. That means it is because of the mineralocorticoid action of steroids. Now, steroids have majorly glucocorticoid action and a little bit of mineralocorticoid action. But if you give high dose steroids, there will be more mineralocorticoid also, and this will lead to hypertension. Majorly because of sodium retention. Remember that increased steroids leads to increased sodium. So increased sodium will lead to increased water, and there will be more circulatory volume leading to increased blood pressure. Additionally, steroids cause vasoconstriction by their self, and they also increase the response to catecholamines. For example, catecholamine induced vasoconstriction. That means vessels are going to constrict because of catecholamines, and in the presence of steroids or high dose steroid, this responsiveness of vessels are increased and will lead to further vasoconstriction, and this is one of the major mechanisms also to cause hypertension. So hypertension is caused by two mechanisms: increased sodium retention leading to increased water, leading to increasing blood pressure, and also vasoconstriction. These are majorly because of mineralocorticosteroids, and remember that in the last presentation we were discussing that majorly the shorter acting steroids have more mineralocorticoid activity. Steroids such as cortisol, cortisone and hydrocortisone, prednisolone have significant mineralocorticoid activities. Additionally, pulse steroids. Now pulse steroid is because they have a longer half-life, longer duration of action, so that it remains in the system for a longer time. So that can have a significant mineralocorticoid action. That is why you have to always measure blood pressure during pulse patients, and also measure blood pressure whenever the patient comes to you, no matter what the steroid dose is. Okay, so you need to have a good blood pressure measurement. Additionally, if steroids are given for longer duration, it will lead to hypertension. If the hypertension is there for a very long time, let's say months, and the heart is not able to cope up with increased blood pressure, it might lead to congestive heart failure, and this can be life-threatening. So you have to make sure that hypertension is managed and it doesn't lead to congestive heart failure, which can be fatal and life-threatening. Now, another significant adverse effect is growth impairment, and majorly it is seen in pediatric population. So, during early years, let's say 5 years, 10 years, 15 years of life, the body needs to grow. And because of this growth is important, it is carried on by growth release hormones, okay, GnRH. Now, GnRH, let me just write it properly, is released in a pulsatile manner. And this pulsatile manner is controlled by endogenous cortisol. If there's increased cortisol in the system, this cortisol, because of its negative feedback, will decrease the GnRH. And when GnRH is decreased, it will lead to decreased growth of the patient. Okay, because of decreased growth hormone and decreased insulin-like growth factor 1, there is delayed skeletal maturation and the bones are not able to grow properly, leading to growth impairment. Okay, but after the bones have grown, this side effect is not majorly cumbersome. But when you're using drugs in pediatric population, when the body is still growing, this can easily lead to growth impairment. Now, how to look for it and prevent it? Plot the height and weight of the patient on a height and weight chart. These are WHO chart. It's available in all OPDs with your pediatrician. It is separate for boys and girls. So you need to keep on plotting it on the graph and see if the growth is impaired or not. Treatment is to taper the steroid and stop them as soon as their need is met. And you can also consider giving growth hormone supplements for the patient to grow. But always discuss with your pediatrician if you are considering growth hormone. So multiple times we come across patients who have taken different forms of steroid from the outside and the growth is severely impaired. So it's better to discuss with your pediatrician, discuss with your colleague whether we should give growth hormone or not. Now, bone side effects are predominantly two types, osteoporosis and osteonecrosis. And these are one of the very important side effects to look for and to prevent. Okay, especially if your patient is postmenopausal woman or elderly patient. Bone defects or bone adverse events can occur in younger patients also. The interesting points about osteoporosis or other bone side effects are that it can occur in all age groups. Plus, it can occur with each and every dose of steroid. There is no threshold that you will give high dose steroid, even low dose steroid can cause them. Third, the bone defect or the bone damage or bone resorption can start as early as 4 weeks. So if you give steroids, it can start in the first month itself and the damage will keep on getting cumulative and compounded. Clear? Now, osteoporosis occurs because of decreased osteoblast activity. So, osteoblasts are bone forming cells, and because of their decreased activity, new bone formation will not be there. Osteoclasts are those cells which eat away the bone and resorb it. So, that is how there's a good balance between osteoclast and osteoblast. So, a good balance is naturally present in osteoblast and osteoclast, and this will lead to bone remodeling. If osteoblast is decreased and osteoclast is increased, it will lead to more bone resorption and more bone damage. Additionally, there is decreased GI absorption of calcium, and there will be increased calcium ion in the system. Now, why is there an increased calcium ion? Because all the calcium in the bone is now getting into blood. So remember that steroids might increase calcium ions also because of this. Okay, but majorly decreased osteoblast activity, increased osteoclast activity, and decreased GI absorption of calcium leads to bone resorption. Plus, there will be increased excretion of this calcium from the blood to the kidneys. One point to remember, body is going to utilize calcium if there is any need for it. Calcium homeostasis is very important to know how the body reacts with increased calcium. A lot of time, majorly every patient is going to get calcium and vitamin D from us. Okay, so we need to know a bit about how the body utilizes calcium. If there's increased calcium excretion from the body, the calcium is not present there to get deposited into the bones and counteract osteoporosis. So all of these issues are leading to decreased bone density and osteoporosis in the long term if steroids are being given. So as I've said, it occurs early, can be seen in roughly about 40% of patients, and trabecular bone is much more affected than cortical bone. Clear? The fracture risk increases by 75% in the first 3 months. So like I said, it occurs early and with any doses of steroids. The fracture risk increases by 75% in the first 3 months. Female gender and young men are predisposed to osteoporosis because of steroids. Okay? It is because that in younger generation the bone is still undergoing resorption, it has not been fixed. So osteoclasts are very well active, and if you increase osteoclast, they will resorb the bone. Okay. Now, remember that it does not decrease with alternate day steroids, and it can occur in lower doses too. So even if you're giving physiological doses of steroids over prolonged duration, it can cause osteoporosis. Clear? Now, treatment of osteoporosis. You have to give calcium and vitamin D supplementation to your patients. That is a must. You have to give them calcium and vitamin D, and the doses are for calcium it is 800 to 1200 milligram per day. For vitamin D it is 800 to 2000 international units per day. So you have to supplement with daily vitamin D and calcium ions. This is for prevention of osteoporosis, and a good idea would be to start the supplementation from the day you give steroids. Clear? For treating osteoporosis, you have to give bisphosphonate. This is the first line drug for treating osteoporosis. Clear? So we'll discuss bisphosphonate for just a little bit and see what all do we mean by that. Now, majorly, there are three bisphosphonates. You have alendronate, you have zoledronate, and then you have risedronate. Okay. Now all of these bisphosphonates have been approved by FDA for treatment of osteoporosis, majorly glucocorticoid induced osteoporosis. So if you read article, you will find GIOP, glucocorticoid induced osteoporosis. Clear? So these three have been FDA approved. Okay, for treatment of osteoporosis. From these three, zoledronate and risedronate have been approved for prevention of osteoporosis. That means you can give before osteoporosis has set in. And all these three for treatment, while zoledronate and risedronate have been approved for prevention. Clear? Now, just a few more points about it. That zoledronate is given as a yearly injection. Yearly IV injection 5 milligram is given, and you have to speak with your endocrinologist, your endocrine colleague, for your patients if they want to receive zoledronate. Alendronate is given 5 milligram daily, or can be as high as 70 milligram in a week, but it is usually given as 5 milligram daily doses for treatment of osteoporosis. Are we clear on that? Now, if on bisphosphonates, if the patient is not able to take bisphosphonate for whatever reason, let's say patient is immobile or the kidneys are not functioning properly for good bisphosphonate mechanism, or if there are other contraindications to bisphosphonate, I'm not going into depth regarding that. Other drugs that you can try are nasal calcitonin. Now what calcitonin does is, if you have a blood vessel and in the blood vessel you have increased calcium, calcitonin will remove this increased calcium and deposit it into bones. Clear? So that's what calcitonin does. So if you give nasal calcitonin, there's an increased absorption by the nasal epithelium and it starts to act right away, and it will shift the calcium ions in the blood into the bone. So calcitonin can be used. Other is teriparatide. Teriparatide is just a parathyroid hormone, artificially made parathyroid hormone, and parathyroid hormone is also does the similar thing, and to accumulate in the calcium homeostasis. Clear? Denosumab. Now denosumab is an inhibitor of RANKL. It's an inhibitor of RANK ligand, and RANK ligand is needed for osteoclast activity. So if RANK ligand is needed for osteoclast activity and you inhibit RANK ligand, there will be less osteoclast activity, there will be less bone resorption. Other thing that this question has been asked by me in my to me in my residency, what is FRAX scoring? So FRAX scoring is a score developed by WHO to find out the fracture risk in a patient, and that is general fracture risk. That means age related, gender related, not particularly because of steroid. And if it's more of like a point system, and after you give points to certain parameters, you'll be able to know what is the fracture risk of the patient. So if possible, I'm not going into details of FRAX scoring, but if possible, it's freely available in the internet. And if you think that your patient has a risk of osteoporosis or osteonecrosis or fractures, you can do a FRAX scoring and mention that in your OPD card. Clear? So we have discussed osteoporosis because of steroids. Now, just a little discussion on DEXA scan, because DEXA scan is the investigation through which you diagnose whether the patient has osteopenia or osteoporosis, and it is one of the most common investigation done when a patient is on high dose steroids. Clear? Now, what is DEXA? DEXA is dual energy X-ray absorptiometry, and it is done to measure bone density. Now, what do we mean by dual? Dual means two different beams of X-rays are passed by the body through the body, and depending on its relative absorptiometry, relative absorption by the tissue, and how much X-ray is absorbed, how much X-ray is reverted back to the sensor, you get two scores. You get T scores, you get Z scores. Okay. In T score, the level of bone mineral density of the patient is compared with another patient of young age who is healthy and has the maximum bone density. That means if I have a patient of 40 years and I go DEXA scan, the T score will compare 40-year BMD, which is more bone mineral density, to a roughly 20-year-old male patient with maximum bone absorption, and it will give you a score. The Z score is similar, but Z score compares same age and same gender patients. That means the BMD of my patient will be compared with the BMD of a normal person not taking steroids, not having those risk factors, but same age and same gender. So that is Z score. Clear? If the scores are less than -1, it's normal. If it is between -1 to -2.5, it is osteopenia. If it is more than -2.5, it is osteoporosis. That's the WHO classification. The area for DEXA scan is femur neck, lumbar vertebra, or hip. Now remember that femur neck is much more trabecular than the other parts of the femur, and as we have mentioned in previous slides, that the trabecular bone is much more affected than cortical bone. Clear? So we take the femur neck as a site for doing DEXA scan and measuring bone mineral density. Clear? Other sites are lumbar vertebra and hip, and it is important that you use the same site for follow-up. So if you have done femur neck first, ideally we do two sites. We do femur neck and lumbar vertebra. If we are using the two sites, use the same sites for follow-up, and DEXA scan is done annually, once a year. Okay? Look at what is the level of bone mineral density, and calcium level, phosphate level, LDH, thyroid, parathyroid levels are all measured and correlated with DEXA scan, and to find out what is the cause of osteoporosis. But if we are doing it for increased steroids, we know that increased steroids are causing osteoporosis, and that's why we do DEXA scan. Clear? Now, osteonecrosis. Remember that steroids increases fat deposition at altered sites at other levels, and one of those is marrow. So if bone marrow is infiltrated by fat deposition, it can lead to compression of the bone vessels. Additionally, there is an hypercoagulable state because of steroids, and this will lead to decreased blood supply to the bone, which is ischemia, and this ischemia will further lead to necrosis. Clear? So that is how osteonecrosis takes place. It is seen when prolonged steroids are given roughly about 2 to 3 months. Also in SLE patients, it is a significant adverse event. In active patients, that means patients who move more, who exercise more, who move about a lot, have an increased risk of osteonecrosis. But for passive patients, there is an increased risk of osteoporosis. Okay, so osteoporosis is more in passive patients, while active patients show more of osteonecrosis. Men show more osteonecrosis, while women show more of osteoporosis. Clear? Your patient may present with focal pain in hip, shoulder, or knee, And if you suspect osteonecrosis, MRI is the definitive investigation of choice. Clear? Treatment is avoid trauma to the site, refer the patient to a person who knows how to manage osteonecrosis, be it surgeon or be it an endocrinologist. It might require prompt decompression or prompt normal blood supply has to be maintained. So just send it to a surgeon, an orthopedic surgeon who will take care of it. And if the necrosis is severe enough to cause significant joint damage, the joint may have to be replaced. Clear? Refer the patient, it will do better. Coming to the gastrointestinal side effects, the major side effect or an important side effect is bowel perforation. And that is because of decreased wound healing, and also because of vasoconstriction, there is decreased blood supply to the wound. Decreased blood supply. And remember that corticosteroid can also cause peptic ulcer. And peptic ulcer we'll be discussing in the next slide. And if the ulcer is severe enough and is not healed because of decreased wound healing, it can perforate through the GI epithelium and the GI wall and can lead to bowel perforation. So remember, if your patient has a recent GI surgery, be very careful in giving steroids. It might lead to bowel perforation. For example, surgeries like bowel to bowel anastomosis, where chances of increased leakage is there, be careful in giving steroids. Now it requires a prompt surgical intervention because if peritonitis happens, patient can die. So it's a life-threatening disorder. So it requires a prompt referral to a GI surgeon for management. Clear? Now coming to peptic ulcer disease, it is because of decreased mucus production because of steroids. Steroid also lead to decreased mucus production. So the lining of stomach is not that protected or prevented. Additionally, there is increase in acid production. So it's better to give countermeasures the moment you give steroids so that patient does not develop any kind of peptic ulcer. Now, total cumulative dose of more than 1 gram is an independent risk factor for developing peptic ulcer disease. Also, concomitant use of NSAIDs. So, let's say if you're giving steroids for majorly indications are arthritis, let's say it is associated with systemic sclerosis arthritis or SLE arthritis or psoriatic arthritis, and you want to give a high dose steroid, remember that if you give it with NSAIDs who individually cause ulcers, it might lead to increased risk of your patient developing peptic ulcer disease, and it can also lead to bowel perforation and can lead to death. So just be a bit careful. Now treatment is to give H2 antihistamines and proton pump inhibitor. Now gastro people or gastro guidelines regarding the use of PPI say that any patient who requires PPI should be given PPI. So if you're giving a patient steroids and you think that the steroids will be given for a prolonged duration, let's say more than a month or more than 2 months, give the patient PPA. Okay, and if your ulcer causes perforation, it is life-threatening. I've already told you. Clear? Now, pancreatitis. We know that because of glucocorticoid effect, the triglycerides are increased. And if this triglycerides is increased to more than 800 milligram per deciliter, normal levels are less than 200. Okay, so if it's increased to more than 800, it increases the risk of pancreatitis. Okay. Usually seen after 2 to 4 weeks of steroids, it will present as severe abdominal pain, and this is also one of those life-threatening disorders. There have been other mechanisms of action like blockage of pancreatic ducts, and because of blockage, there is reflux of pancreatic enzymes which digest the enzyme, digest the pancreas, causing pancreatitis. Other mechanisms are also there, but the major risk factor is increasing triglycerides. Clear? And this is a life-threatening disorder, has to be managed very quickly. Coming to ophthalmic side effects, the major side effect is cataract, and that is the mechanism of action. How do steroids cause cataract is very uncertain, and altered lens proteins have been implicated. Now, how do these lens proteins get altered? It is mentioned that steroids binds to lysine, and lysine is an important amino acid in our eye lens. And because of binding, it leads to clumping and cloudiness of the lens, causing cataract. Additionally, sodium potassium pump inhibition also happens because of steroid, and because of sodium potassium pump inhibition there is H2O retention. Water is retained inside these cells, and this can lead to further clouding. Third is coagulation of lens proteins. Coagulation of lens proteins, and this can also lead to cataract. So I've told you about three different reasons why cataract can occur on steroids. Additionally, steroid increases blood glucose, which is an independent risk factor of cataract. Now, what kind of cataract occurs? And this is an important question for your, in fact, for a PG entrance or Viva. Posterior subcapsular cataract is implicated. For that, if your patient is receiving steroids, do a simple torch examination and see the clouding of lenses. It's very easily visible. Okay, and slit lamp every 6 to 12 months is recommended. So every 6 to 12 months, get a slit lamp examination to screen for cataract. If cataract is found to be there and it is significantly impacting vision, it will impact vision. Counsel the patient to get cataract surgery. It's one of the easiest surgeries in ophthalmology, and they are ready to do it. And during cataract surgery, you can even implant an intraocular lens, an artificial lens, and patient can be free and have good clear vision. Other side effects is glaucoma, and that is because of increased intraocular pressure. The mechanism is that there is a trabecular network inside the eye. Trabecular network. Okay, a trabecular network is just like a sieve, a mesh, through which aqueous humor in the eye is degraded and absorbed by the blood vessel. If that network is blocked, there will be increased aqueous humor inside the eye, and this will lead to increased pressure on the anterior chamber of the eye, causing glaucoma. Okay. Additional side effects are refractory changes can also occur. Now, psychiatric side effects of steroids. These include agitation, psychosis, and depression. And majorly it is because of electrolyte shift. Remember that increased steroids have increased sodium, decreased potassium, and because of this, changes of electrolytes can lead to different psychiatric symptoms. Additionally, altered nerve excitation and cerebral edema can also lead to this kind of psychiatric disturbances. If a patient has family history of neuropsychiatric symptoms, they are at an increased risk of developing these kind of psychiatric issues with steroids. Depression may occur during tapering. Remember that when we were discussing about steroid withdrawal syndrome, and we said that when steroids are withdrawn abruptly after giving steroid for a prolonged duration, patient may complain of lethargy and low mood and low activity and depression. A frank depression can occur when the steroids are being tapered. Okay. 60% of patients will complain of some kind of psychiatric disturbances within the first 2 weeks of stopping steroids, and this can increase to 90% within 6 weeks of stopping steroids. Clear? Most common psychiatric disturbances is mania, seen in 30% of patients, and 20% of patients can have depression. It's a variable statistic, but 30% mania and 20% depression have been mentioned in books. If your patient has any kind of psychiatric issue with steroids, get psychiatric help. That is important. Talk to your psychiatric colleague and get a good amount of psychiatric evaluation done for your patient. It might be very helpful. Do not start counseling or treating your patients if they are developing steroid-induced psychiatric issues. It is very variable, and like any other psychiatric issues, you should take help from your psychiatric colleague. Okay. No harm in taking help always. Whenever you need help, take help. Don't be shy and don't be stupid. Opportunistic infection. That is because of irrational immune suppression. In the previous presentation, we discussed how steroid decreases nearly all cell lines, and one of the major cell lines in that were the immune cells. Majorly, T cells were being suppressed more than B cells. That means cellular immunity and innate immunity is suppressed more than humoral immunity. Clear? And because of this immunosuppression effect of steroids, the body is more susceptible to different kind of infections, and those infections can be anything. It can be increased bacterial infection, it can be increased viral infection, Fungal infection, remember that during COVID pandemic, increased steroids was leading to increased mucormycosis or in fact, increased aspergillosis. And it has been found that in a patient of prolonged immunosuppression, if there's fungal infection, the nasal sinuses are not that much affected. You see more in the pulmonary parenchyma, in lungs. Clear? If the patient is on prolonged high dose steroids, the patient has an increased risk of developing opportunistic infections. The risk will decrease a bit with every other day's doses of steroid. That means alternate day helps to decrease this side effect. The relative risk of tuberculosis, one of the most important disease in our country, rises to about 7.7 if a patient is taking significant steroids, be it significant in duration or be it significant in doses. Clear? A thorough and detailed history and examination is absolutely necessary to find out whether your patient is having some kind of infections or not. Now, remember, if your patient is having, let's say, a significant significant inflammatory disease, let's take an example of pemphigus vulgaris, and if your patient also has eczema herpeticum, and if you give high dose steroid in those patients, it will be a havoc for the patient. So if your patient is severely immunocompromised because of any kind of steroids taken from outside, and you decide to just supplement that and prolonged steroid induced immunosuppression, and patient also has an opportunistic infection for which you have not screened, it will be very detrimental. Now, remember in the last presentation, I told you a story about strongyloides infection. One of my patient of Hansen's had strongyloides. That is also one of the infections in our country. So it's better that if you're starting steroids and if you suspect steroids to be given for a longer duration, get a chest x-ray done, get a urine routine microscopy, if required, get culture sensitivity, get a stool microscopy to look for ova and cyst. If there's anything on the chest x-ray, get an IGRA done, rule out active tuberculosis, take help from your pulmonary colleague, and make sure the patient doesn't have any opportunistic infection. Treatment is as per infection. If it's aspergillosis, antifungals. If it is bacterial infection, give antibiotics. If it is viral, give antivirals. To make sure that treat the patient for this respective infection they are having. Now, myopathy. Remember that because of peripheral insulin resistance, the steroids are going to decrease the amount of glucose that enters the muscle. So if this is a muscle, let's say this is a muscle, so there will be decreased glucose entry inside the muscle, and because of decreased glucose entry, the muscle may not be able to contract properly, and this will lead to muscle atrophy, somewhat of a disuse atrophy. Fluorinated steroids like fludrocortisone, or rapid tapering of steroids or lack of exercise can lead to myopathy. More than 30 mg per day of steroids, if the patient is receiving, it is also additional risk factor for myopathy. So remember that whenever you give steroids, counsel the patient to do regular exercise. This will help in decreasing myopathy. This will help in decreasing lipids. This will help in keeping good mood for the patient, and this will help in decreasing the blood glucose level. So you cannot underestimate the power of a good regular exercises if the patient is on steroids. Even without steroids, it's good to counsel your patients for regular exercises. Muscle enzymes are more or less normal. So multiple times you will see that if, let's say, if you have a patient of connective tissue disorders and there is associated muscle damage, you will have a problem in deciding whether to increase steroids or not. Let's say muscles are being damaged because of an autoimmune disorder. So if you increase steroid, this will get okay. This will get properly improved. If muscles are getting damaged because of increased steroid intake, if you increase steroid, the muscles will get more damage, more problem. You have to decrease, taper, and stop steroid. Okay. So you have to find out whether the muscle damage is because of steroids or is it because of disease. The muscle enzymes will be raised if it is because of disease. It will be normal or more often normal when steroids are the culprit. Treatment is gradual and slow tapering of steroids, and subsequently ask the patient to do exercises so that the muscle regains its strength. They're able to uptake more glucose and amino acids. Clear? Opportunistic malignancies. Some malignancies like Kaposi sarcoma, non-Hodgkin lymphoma, squamous cell carcinoma, Merkel cell carcinoma have been implicated with prolonged use of steroids, and it usually seen in patients who have taken steroid for a longer duration, high-dose steroids, long-acting steroids, and also steroids combined with other immunosuppressive drugs like methotrexate, cyclosporin. So if you are using multiple classes of immunosuppressive drugs and patient is on prolonged immunosuppression, the chances of these kind of malignancies increase a lot. And these opportunistic malignancy can be life-threatening. So you need to be on lookout. For example, for lymphoma, it's a good idea to examine lymph nodes at baseline level, and if the patient complains of any kind of swelling, examine it. So a good thorough history and examination will be easily able to screen this kind of opportunistic malignancies. Now, cutaneous side effects. Cutaneous side effects, we will just discuss a little bit because we usually know somewhat more about them. Wound healing and related changes. I have already told that wound healing is decreased because of decreased collagen, decreased ground substance, decreased reepithelialization, decreased new vessel formation. Additionally, there is flattening of rete pegs. Flattening of rete pegs or the papillae, rete pegs. That gets flattened. There is decreased mitotic activity in keratinocytes. So there is decreased division in keratinocytes. There is decreased fibroblast. Remember in the last presentation, while we were discussing the action of steroids on different cell lines, I told you that fibroblast gets decreased. In pilosebaceous, there can be an altered increased pittosporum ovale and also increased androgenicity, because that is also one of the steroids congeners. And through toll-like receptor 2, through mediation by toll-like receptor 2, it can lead to steroid acne. Okay. And in previous presentation, we were discussing that it increases the homing, I don't remember exactly, I think it's CCR10. So because of increased homing molecule CCR10, more inflammatory cells get home to the skin because of steroids. Okay, steroids increase CCR10. Because of increased CCR10, more inflammatory cells go into the skin, and there will be more inflammatory damage. It's somewhat of a paradoxical mechanism, and this might lead to steroid rosacea. Okay. A catabolic effect on vascular smooth muscle happens, and because of that, it can lead to increased vessel damage, leading to purpura because of steroids. Increased cutaneous infections like staphylococcal, bacterial viral infections can happen. We have already discussed about eczema herpeticum in previous slides. Okay, telogen effluvium and hirsutism. Hirsutism is a very discomforting side effect of steroids or patients taking steroids. Now, injectable corticosteroid, we had discussed in the last presentation, what are the adverse events which is restricted to injectable corticosteroid, and lipolysis of subcutaneous fat has been implicated, fat atrophy, and because of that you see the localized atrophy when you give intradermal or subcutaneous or intramuscular injection. Clear? Now, pregnancy risk. Risk to the fetus in the form of stillbirth, spontaneous abortion, cleft lip and cleft palate has been documented. The steroid passes through placenta and can easily reach the developing fetus and can suppress the HPA axis of the fetus also. Okay, so fetal HPA axis suppression has also been documented, but during pregnancy, steroids are considered more or less safe. The newer pregnancy category is moderate to high risk. The older one is category C, except budesonide, which has B, and except deflazacort, for which a previous category was not assigned. But the newer category, as per the newer classification of risk during pregnancy, is moderate to high risk. Steroids are also secreted in breast milk, so make sure you keep that in mind while prescribing steroids to lactating mothers. Now, some additional points. We are just nearing the end of the presentation. These side effects can be classified into two parts. One is linear. The second is threshold based. Linear means that whenever you increase the dose, the side effects will also increase. Side effects like ecchymosis, leg edema, sleep disturbances, they all increase with the dose of steroids. The threshold is that it does not increase that much with increasing steroids, but when it crosses a certain level, they start to appear and then start to increase. So elevated frequency after a certain threshold. Side effects like hypertension, glaucoma, and depression are threshold-based side effects. Just to mention because it was mentioned in books. Now, what are the principles that as dermatologists we can keep in mind so that we can help our patients, we can find out these side effects, we know how to deal with it, we can discuss the therapies with the patient, all the common side effects that the patient might have, and we are in a better position to use steroids. So remember that corticosteroids should be used for only appropriate and well documented indications. We should know what we are treating with steroids. Okay, we should have some indication, and we should know why we are choosing steroids over other drugs. So we should be clear in that. It should be documented. We should make sure that patient thoroughly understands the serious potential steroid complications. So they should know about them, and they should be, for example, some danger signs should be explained. And if there's any home monitoring like home glucose monitoring or weight monitoring, they should be explained to the patient. Patients should be thoroughly educated about the steroid use, when to take the drug, how to take the drug, how much to take the drug, what are the associated risk factors, associated adverse events. They should know about it. Match the aggression of corticosteroid therapy with the risk of the disease being treated. That means whatever is the value of, whatever is the intensity of the disease, it should be matched by the amount of steroids you are giving. I always say that treatment should match the disease. We should not overtreat, we should not undertreat. No half-hearted measures. Give the amount of steroid required to control the disease activity. Find the lowest possible effective corticosteroid dose as soon as possible. You start with the steroid dose, let's say 0.5 mg per kg, you may increase to 1 mg per kg. Find the lowest possible effective steroid which does the work as soon as possible and maintain the patient on that, and then quickly shift it to another non-steroidal immunosuppressive drug if the duration of immunosuppression required is long. If it is short, then you can gradually taper and stop steroids only. Have a non-perfectionist mindset. Do not keep that in mind that I will achieve complete disease control by using steroids only. Steroid is to be used to tide over the current acute crisis and to give patient enough window period so that we can shift to other immunosuppressive drugs which are not steroids. Clear? So it's not like you keep on giving steroid for months and years altogether just to control this activity. If the patient is having repeated relapse, consider other drugs. Don't keep on giving steroids. Use the attack or retreat, or the term that I use is hit and retreat. That means you hit the disease with adequate amount of steroids which is necessary for control the disease, and then you retreat. You come back, you decrease the dose of steroids, and then you taper off and stop steroids. Okay? Go in, control the disease, come back. Hit and retreat. Clear? Now, seek to shift the daily dose of steroid to alternative doses within 1 to 2 months so that the side effects are decreased to a significant extent. Consider corticosteroid sparing therapy. For example, if you can shift to any topical drug or any systemic drug which can better take care of patient in a prolonged over a prolonged period of time, it's better to shift the patient to that. Take into account all the risk factors and all the contraindications for corticosteroid therapy and manage those as required. If your patient is developing high blood sugar, manage with drugs, manage with exercise, manage with diet control, high lipids, manage accordingly. So keep on managing that. Keep on monitoring your patient for all the electrolyte and metabolic changes. Make sure you do blood investigations routinely. We have discussed the monitoring aspect in last presentation, but keep on doing it in a regular basis, monthly or every 3 monthly, so that you have a clear understanding when these parameters are getting out of hand. Take help from different colleagues and manage the adverse event. Okay, just because you are the primary caregiver or primary physician doesn't mean that you will manage each and every adverse effect on your own. Take help, refer, call, do anything if you want, and discuss the case with your colleagues and find the therapy which is best suited for the patient. Clear? In general, and this is one of the important boxes, in general, a proactive and careful clinician will always anticipate the risk factors, know what are the risk factors, know what are the contraindications, Prevent, that means keep on monitoring and measuring these parameters and finding out whether they go out of hand. Diagnose early, you do all the lab tests, home monitoring of these parameters, tell the patient what all to expect, and then manage. So when the adverse events occur, you are in a better position to manage. So you know what the risk and contraindications are. You prevent these adverse events. You diagnose them early and you treat them early. And with that, you'll be easily able to use corticosteroid in your patients, and you'll be you'll be safer in using these drugs in your patients. Okay. With that, I stop the second part of our presentation. The next part would be the third part, and it will deal with corticosteroid pulse therapy. So we'll be discussing all the IV pulses, their modification, oral betnesol pulse, oral mini pulse, and we'll be discussing the uses, mechanism of action of and adverse events of these pulses in part 3. Most likely this will be the last part in corticosteroid series, and we'll be finishing up the 3 parts. So remember that if you know what steroid to give, what is its mechanism of action, what are its effects, what are its associated adverse events, you'll be much more comfortable in using these drugs in your patient. Do not be afraid of adverse event, but be on the lookout and read and learn more about how to manage these adverse events. Go in, manage the acute crisis, come back, taper the steroid, stop the steroid as soon as possible, or shift to other non-steroidal immunosuppressive drugs. Clear? With that, I'll finish my presentation. If you have any kind of doubts, just mention them below the video and I'll answer them as soon as possible. You can even email me separately. If you have any other questions during the presentation, any other questions you have been asked in Viva and you want to know how to answer, what is the answer, so please ask so that we all can search and learn from it. And if you have any other suggestions how to improve these kind of presentations, what all else do you want, just let me know and we'll make a presentation and discuss. Okay, so I shall meet you next week with the part 3 and the final part of oral systemic steroids in dermatology, and we'll finish with IV pulse steroid therapy. Okay, with that, adios and goodbye.